3 questions. They're the only questions you need to know about advanced airway. I don't care about any others. Will I be able to ventilate and oxygenate? We've covered that. Will I be able to intubate? And will I be able to do something with the cricothyroid membrane? So ventilate and oxygenate, we've done that. You're able to do that. You can bag valve mask, the cows come home. Okay? Will I be able to intubate? Does the patient have a history of a difficult intubation? If there's a history of a difficult intubation, ask what was difficult from a relative or ambulance or whoever, and find out what they did if you can. Otherwise, these are the things that make it difficult. Trauma, infection, edema, hemorrhage. Okay? They distort the anatomy. It's easy. But make sure that you've had a look, because this sort of distortion or disproportion or previous surgery will screw you over when it's time to do it. Tongue, have they got a big tongue? What's happening with their pharynx? We're going to talk about the 3-3-2 rule. Who's heard of the 3-3-2 rule? Really important to do it very quickly as a patient comes in. We're going to go through it all. Dysmobility. Can they move their neck? Okay, little old ladies that come into the emergency department don't have vertebra, 6 or 7. They have a unibra. Everything is kind of fused, so they move like this. You can't do this to them. Or have they had trauma, so you can't move their neck? Dentition, big front teeth. What are you going to do? Small mouth opening. I want to show you some of those. Improving your chances of survival is predicting. Now, predicting is not about sort of predicting and getting all your equipment in place. Predicting is about getting the mindset right that this could be a bit of a scorcher. And so you've got to think about, what am I going to do? So predicting is about emotionally preparing yourself, psychologically getting ready for a difficult tube. So prediction is about looking at the patient, making a quick assessment, and then saying, this is going to be harder than I think it's going to be. I'm going to get one other piece of equipment and start with that. If we predict it's going to be a difficult airway, we can't change that. It's going to be a difficult airway. You just mentally get ready for it. Predict is difficult debate. Kids can be difficult if they've got a massive tongue. I find kids easier than adults. But if they have a really massive tongue, and if you start putting a laryngoscope in there and slashing some of that soft tissue and it starts to bleed, very difficult to tube the child. So be very, very careful. Trauma, we talked about it, the C-spine, not being able to. Facial trauma, could that be a problem? Can the top one be a problem? Hey, look, all those lips are out of the way. I like that. Only bleeding could be a problem there. How about the middle one? Somebody had an argument with their son. All right, that could potentially pose a problem depending on where that knife's gone. If it's actually transected part of the trachea, you're in deep trouble. So, but that person looks pretty comfortable there with a Hudson mask. And the bottom one, where they've had a gunshot to the face, that's the best one. I can actually see the vocal cords. Facial anthropometics, short neck, a beard, no mandible, they can't open their mouth, big teeth, big problems, all right? Okay, really important. Hemifacial microsomia. One of the things that we depend upon when we're looking at the mouth and opening it up is asymmetry. Once you've got asymmetry, it actually can become very, very difficult. Trisomy 21, big tongue. Remember, that's our enemy. Moving the tongue out of the way is our enemy. Big tongue, look at it. It's going to be very difficult to push out of the way. Microstomia. Put a laryngoscope in there. That's a potential problem. Micrognathia. What's the problem here? Where is the tongue going to go? Where are you going to push the tongue out of the way? And in kids, because they have a bigger tongue, that's why we talk about a straight blade in kids. We use a straight blade because if you try to use a classic curved blade, look at how much space that takes up. Okay? And that's why that's the reason we use a Miller's. That's the only reason we use a Miller's in kids. Because this takes up huge amounts of space. This takes up very little. And they've already got a big tongue, so you want to minimise how much space you're taking up. The lemon approach. I love the lemon approach, okay? This is a really simple way to just, who's heard of it? Lemon, yeah. Really simple way to think about it. Look externally. Are they big? Do they have a high arch palate? They got a narrow face, no neck, massive beard, So just do a quick external review of the patient who sees this. Going to be difficult. And we do the 3-3-2 rule. Evaluate this. Now I want you all, usually I actually take a picture of the audience. I haven't got my camera today. I have a picture of every airway workshop, the 3-3-2 rule. So 3-3-2, 3 fingers. Mouth opening, 3. I want you all to do it. 3. Can you get 3 fingers in there? Okay. I struggle. Okay. 2, 3, thyromental distance. So you want to go from the tip to the hyoid bone. Who can get 3, or who can get more than 3? Okay. So if you get more than 3, it increases the oral axis length. That may or may not be a hindrance. Less than 3, you could have too small a space here and not be able to put the tongue into it. Okay? And 2, the hyoid bone. So the hyoid bone is the first bit of bone you touch right here, and the thyroid notch. So you've got to get 2 in there. Most people do get 2. If you don't get 2, you may have an anterior larynx. Okay? So 3, 2. Now when you look at a patient coming in, you will see whether they can open their mouth purposely. Yeah, if this is a semi-elective, if they're unconscious, well, you can't judge that, all right? But you will be able to see what they have here, and you will in most cases see whether they've got a short neck. This is all this is telling you. Have you got enough room to get in? Have they got enough room for you to push their tongue out of the way? And have they got enough of a neck that the cords are going to be somewhere that you can see it? That's what the 3-3 rule tells you. So you can do a quick review of that when the patient comes in. Mallampati. Who's heard of Mallampati? Okay, Mallampati was an anaesthetist who developed a classification for people sitting on the end of the bed, so it's different to what we do. Sit on the end of the bed, he said, open your mouth, don't say a word, let me see how far in I can look. And he came up with 4 classifications. And that's what they look like in real life. You can see everything, you see a little bit less, you can't really see much of the back, you see diddy, nothing at all. Okay? 4 classifications. Great if you're sitting, how does it relate to us? All it tells us is the sort of mouth opening as far as I'm concerned. How much can you get the mouth open and what can you see in the back? The significance of it is though that if you have a class 4 Mallampati, your chances of missing a tube are greater than 10%. Okay, makes it difficult when you're down to 4. If you have this sort of a view, which most people have, that's fine. Okay, but when you can't see any anatomy in the back, start thinking. All right. Now, who's going to be doing that for us? Not your unconscious patient, but you might have your congestive cardiac failure patient. You're just about to tube, and you'll do a quick assessment. Say, open your mouth for me. Obstruction, tumour, epiglottitis, all those other things can make it very, very difficult. And neck mobility, we spoke about that. Okay, so if they can't move their neck properly, if they've got some trauma, if they're elderly, if they've got a collar, they're going to be difficult. Okay? You don't get paid to put a tube in. You get paid to know what to do when you can't get a tube in. Now, rapid sequence intubation is the way we give a couple of drugs, one that relaxes you and one that paralyses you, puts you to sleep, and so we facilitate intubation of the trachea, make it as easy as we possibly can. These are all the indications. You need to memorise all of these, okay? So, all right. This is all you need to know. If there's failure now or imminent failure of oxygenation or ventilation or protecting your airway, so if there's failure right now or if the patient is going down the tubes, then that's when you have to protect the airway. And the only other time is when you do a semi-elective, when you have to tube for, what's a semi-elective?
We had one AF within 48 hours and, she could have gone.
Zap them back, or is that what you're talking about? You give them a shock?
Yeah, shock,
yeah. Or...
Joint. You have a dislocated hip joint sometimes.
So you get, the classic one is your intoxicated patient that comes in and you don't know whether they've had a head injury, you need to scan them, but they're not going to keep still, or you're not sure if they're protecting them. You might tube them, do the scan, extubate them. So the P's of intubation. I only use the P's of intubation to teach. The P's of intubation are all about common sense. Get your stuff ready, predict what you're going to do, tell everybody around you, do it, and make sure the patients are right afterwards. Okay. P's are great for teaching, they're not good for anything else. That's fine. So preparation, position, pre-oxygenation, pre-treat your patient, paralyse them, protect the airway, placement and proof, and post-intubation care. We're just going to use that as a skeletal structure. Preparation and position. Make sure you've got all your equipment ready. Okay, if you know you're going to have a difficult airway coming in, start getting your stuff together. Make sure you've got IV access, all your drugs are up, test your equipment. Make sure your balloon goes up in your endotracheal tube. Make sure the light works. Make sure all of these things are right. Who's going to be doing what? Get your team ready so everybody knows their role. So, you know, you will tube, I will supervise, you will tube, you will scribe, you will give drugs. If there's not enough people there, and in some cases there's not enough in EDs, you might be doing the tubing and running the thing. One, somebody else is going to give the drug, and there'll be one other person. So you're going to need about 3 or 4 people for one of these, but you don't need more. Okay, but make sure everybody knows, because if you ask somebody for something, so when you started giving them thiopentone and they dump their bundle and they drop their BP and you say, oh, can we get some fluid pumped in? Well, who's going to do that? Or can we get some metaraminol up, please, quickly? Who's going to do that? Make sure there's one person there that's designated to that role, and make sure you're nice to people. Basic equipment, as I said, don't start using fandangled bits of equipment. This is going to be your basic, this is your bread and butter. You're going to learn how to use this, and the reason people don't tube or can't tube is only 2 reasons. The position is wrong and they don't know how to use this. There's only one technique you need to know, and I'll teach you how to use this. You don't swivel, you don't bend, you don't lever, you pull in a particular direction. Who's used a McCoy blade? Okay. I tried it once. I had a difficult tube and I said, well, this could be a difficult tube. Let's try a McCoy blade. And while I tried to coordinate my hand to sort of push this while I pulled up, it was just useless. I got rid of it and used a Macintosh. If people don't know what a McCoy blade is right at the base of it, this little bit of it swivels. So the whole idea is it actually picks up your epiglottis and just pushes it out of the way, right? But there's a lever back here that you've got to kind of coordinate, pulling the lever to pull that up when you're kind of in, but most of us are used to doing that, and so we kind of push the thing in inadvertently, and unless it's the blade you use all the time, don't use it. Don't start using lighted stilets and all sorts of weird contraptions, and somebody says, hey, we've got a $10,000 glide scope here. Fantastic. How do you turn it on? Okay, this is not the time. Don't start using fibre optics. Position. Position, 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 we all hear, is the most important thing. We went through all of this. Pre-oxygenation becomes important because what we want to do is have a reservoir so we have the maximum amount of time we have, 3 minutes, 4 minutes. We give 8 vital capacity breaths if we can, okay? Give 2 or 3, whatever you can. Get something in there. Because you don't know what people's functional residual capacity is going to be. If they're crashing, get whatever you can in, and you'll actually, I think on one of the videos you hear me say, no, don't bag now because you've already given the paralytic now. You've got to be very careful at that point. You stop bagging once the paralytic. So there is a physiological response to laryngoscopy and to intubation. You've got to know about that. There's a sympathetic and a parasympathetic response you can also get. Now, when you pass the laryngoscope down, you get a tachycardia in most cases. Okay, causes a sympathetic response. You get a tachycardia as a response to the laryngoscope. Now, once you intubate a patient, if they're tachycardic, you want to blunt that response a little bit. So do people know what they might, I mean, you might give some more of the sedating agent, but a really nice, simple agent to give is a little opioid, a bit of fentanyl. 100 mics of fentanyl straight in, hemodynamically stable, and it blunts that response significantly. And it's the only drug out of the load formula, which we'll talk about, that I use. In the respiratory system, you can actually get laryngospasm and bronchospasm if you don't do this properly. And one of the main causes of laryngospasm is that the patient isn't deep enough. Okay, they're awake and their vocal cords are then irritated. One of the things that you sometimes do, you don't suction the patient enough, okay, even before you tube. And you get something touching the vocal cords. That's why you don't want anything falling back into the vocal cords. They can shut up, okay? Now, when you paralyse them, they'll hopefully open up for you, but they don't need very long to cause APO. Okay, that's what happens if you get significant laryngospasm. Central nervous system, one of the most important things we know about is cerebral perfusion pressure. That's what we need to maintain in patients with head injury. And that's made up of mean arterial pressure minus intracranial pressure. So you don't want to do anything that raises the intracranial pressure too much because your cerebral perfusion pressure drops, okay? So you want to be careful of hypotension that can sometimes occur. So you want to make sure you've got something in line there that you can quickly use. And a very nice drug is metaraminol. A better way to do it is not to use too much of your anaesthetic drug. So really, there's a lot of drugs we can pick from. But thiopentone tends to be the standard in terms of the barbiturate we use, and succinylmethonium. Okay? Does anybody use propofol?
Yeah,
Yep. No, for intubating. Yep, okay. That's fine too. It's what you're used to. I prefer thiopentone because I'm used to it. It doesn't make any difference. In fact, propofol then is what we sedate with. Particularly if you've got an intracranial injury, it's one of the things we talk about.
So how times have changed. When I first recorded this video, I basically said the thiopentone was a drug we use. We hardly use propofol. We only use it for sedation. And succinylmethonium is a drug of choice. And ketamine is something we don't really tend to use a lot. How things have changed. My preference now, of course, we have thiopentone still, but it's not that readily available. So propofol tends to be one of the drugs that we can use. We certainly still use it for sedation, but my drug of choice these days is actually now ketamine. So we can use I actually titrate the dose up. If I'm sedating a patient, I use 0.5 milligram per kilogram aliquots, up to 1 milligram per kilogram aliquots. You can use twice that amount to actually provide the induction dose if you're about to intubate. And the beauty about ketamine is that you can use it as part of this new process called delayed sequence intubation. So normal sequence intubation is rapid sequence intubation, where you give them the induction agent, you slam in the paralytic, and then you tube them 30, 45 seconds later. Delayed sequence intubation has a role when the patient is actually has low saturations, because and they may be fighting the CPAP or BiPAP machine. So classically, you might then give a small dose of ketamine, like 0.5 milligrams to 1 milligram per kilogram. So you put them in a dissociative state. However, they maintain their airway reflexes. And what you then do is you oxygenate them up. And once you've oxygenated them up, you can increase that dose of ketamine, give them the paralytic agent, and intubate them. Now, how about the paralytic agents? We've got succinylmethonium versus rocuronium. Succinylmethonium has been the drug of choice for years and years and years, but it's actually a drug that has a lot of side effects to it, and it's a drug that you can't use in some situations, and it has problems. The biggest thing going for it is its rapid onset, rapid offset. However, we do have rocuronium, and rocuronium at 1.2 milligram per kilogram, that's lean weight, gives you the same intubating conditions as succinylmethonium, and it has absolutely no side effects. So you don't have to worry about thinking about whether this patient has had a stroke in the last 6 months, or whether there's some recent crush injury, or whether there's something else going on, or you don't have to even think about malignant hypothermia and be vigilant if the patient raises their temperature, or if they're not able to relax enough afterwards. Rocuronium doesn't have any of those side effects. What it does is it has a long duration of action, so its action can be up to about 40 minutes, 50 minutes. Some people consider that to be a disadvantage. My view is once you're committed to intubating the patient, you are committed to intubating them or securing that airway. We do have a reversal agent for just sugametics, so we can reverse rocuronium. One of the benefits of a more delayed onset of action is too that if you're having a difficult time with your intubation, in some cases succinylmethonium will wear off. Rocuronium stays on for quite a while, so you don't have to repeat the dose. My favourite two drugs are ketamine for induction and rocuronium as my paralytic agent. What you've got to use those is the drugs that you're familiar with. So you may like propofol and succinylmethonium, and that's what you've got to do. The one thing you've got to be careful about with propofol is that you don't give too much. And in the elderly, you can drop the blood pressure very quickly. In trauma patients, etc., it can be quite a dangerous drug to give. The only thing to say about ketamine is I wouldn't give it to the hypertensive patient. Now, there's no issues of giving it in trauma, or it doesn't raise intracranial pressure, but it does have the capacity to increase blood pressure, and so I wouldn't give it to the hypertensive patient. The other benefit of ketamine may be, and of course there's no great studies on this, there was a study done in, I think, 96 and one in 2005 that showed no benefit of ketamine in asthma. However, they're using small doses. They were using 0.2 milligram per kilogram. And in some cases, if you're using delayed sequence intubation, you may find that you don't need to intubate those patients after you've used ketamine and you've oxygenated them up a bit. So that's just an update because things have changed in the last few years, and I've changed what I do, and I'm now, my choices have changed. So you use what you used to, but you need to think about the versatility of the drugs that you're using. So ketamine and rocuronium are my choice, and I invite you to read the article or the blog that I've written on delayed sequence intubation and on rocuronium versus succinylmethonium.
And placement, I'd like you to put it in there, thank you, all right, in between those vocal cords. Now, when you start, sometimes we watch the clock. I go, okay, 45 seconds, you watch them defasciculate, you do this, they're really flaccid, we're ready to go. Okay, that's what you usually will do when you give them succinylmethonium. Now the burp manoeuvre, we'll talk about that now. Burp manoeuvre has been something that's been confused in the past. It stands for backward, upward to the right pressure. Who does the burp manoeuvre? Is it the doctor doing the tube? Is it the nurse that's doing the cricoid, or the other doctor? Who does it? That's what everybody thinks, and so they're wrong. It's the doctor who's supposed to do it. Because backward, upward to the right, who's right? The patient's right? Or the doctor's right? See, if you're doing it from the top, it doesn't matter. It's the same. If you're doing it from the bottom, that's where confusion is. So the burp manoeuvre was initially designed to be done by the doctor to position so they could see. So once you're doing this, you position it backward, upward to the right. I can see the cords here. Can you hold it right here now for me? The extra hand comes in, you push it, you hold it. Okay, I can see things now. In I go. Okay, Cormac-Lehane, who's heard of the Cormac-Lehane classification? Cormac-Lehane is about what you see when you're in there. So number one classification, Cormac-Lehane. So when we say a grade 1 tube, that's it, you see everything. Grade 2, you see a little bit less. Grade 3 and 4, forget about it. Okay. There's a better classification than that called the POGO classification, which is the percentage of glottic opening. Now that shows you how much glottic opening you've got. But when we go back to Cormac-Lehane, it only applies for 1 and 2, right? And then how do we make sure that it's in? End-tidal CO2. Okay, end-tidal CO2. So we want to see it going through the cords. Does that guarantee it's in? No, right? You'll hear people say, did you feel it going through as they've got the cricoid pressure? And they go, yeah. Is that proof? No, right? You want to see it in there. If you do a 3-point check, you do a 3-point listen after they've gone in and you're bagging them, right? To make sure there's no sounds in the stomach and there's sounds in the lungs. Is that guaranteed? No. End-tidal CO2, gold standard. So you want to see a trace and you want to see at least 5 or 6 of those traces. 2 or 3 may be due to gaseous barley-induced mixtures in the stomach. Okay, beer can produce CO2. So you want to see 5 or 6 if you can, and you're aiming for an end-tidal CO2 in most patients, 32, 35, somewhere in there. Okay, there are some other devices. If you don't have a device like this, you can use a Toomey syringe if you want to, a very simple Toomey syringe on the end of a tube. And so you stick your syringe at the end of a tube and you pull the plunger out and in. Now, if it's in the trachea, if it's in the right place, you should be able to do this. Okay, don't worry about it, I'll show you that in a second. You just should be able to do this. If it's in the esophagus and you go, the esophagus will go, right, and close. It's soft muscle. Okay. You might have a litmus type of approach to end-tidal CO2. You might not have the end-tidal CO2 traces. So what will happen here is it'll change colour to match the level of CO2 that you've got. And you're sort of aiming at around about a yellow for most of these. So here's my end-tidal CO2, makes it go yellow. Okay. And there are some, let's see how quickly I go to the other one. There you go. I must admit I've never used one of these. I'd rather see the trace. There's these other little devices at the moment. I can't remember who produces this one, but I got to use it for a little bit. And they actually give you an end-tidal CO2. Oh, you go, LMA produces them. I don't have any interest in these. I don't own any. I don't have shares. I just play with them. And so with this one here, it doesn't need any time to warm up. You kind of take it out of the box, turn it on, ready to go. Doesn't give you a trace, but it gives you a reading of end-tidal CO2 and a breath rate, which can be quite useful. Okay. So hyperventilation, this is what we spoke about before. So in arrest, it increases your intrathoracic pressure. If you're pumping all this air in, you're pumping out the chest. What's that doing? That's constricting the large vessels in the mediastinum. So it decreases your cardiac return. If you decrease your cardiac return, you decrease your coronary perfusion pressure. If you decrease your coronary perfusion pressure and you decrease your cardiac return, you drop your blood pressure, you decrease your cerebral perfusion pressure. Because remember, it's equal to mean arterial pressure minus intracranial. You drop your mean arterial pressure, you're in trouble. So it's associated with death, basically, in an arrest situation if you do this. That's what it's saying. If you're ventilating, and there's good evidence for this, in an arrest scenario, if you're getting them back and you're ventilating more than 10 per minute, 0 survival. So don't hyperventilate the patient. So post-intubation care, after you've passed the tube, secure the tube, get a chest x-ray, make sure it's sitting in the right place. Giving your paralysis, your sedation, make sure the eyes are fine, pressure, all the rest of it. Be very, very careful and make sure your ventilator settings are right. What if you can't intubate? Okay, what's the definition? You've got to have a failed, the other guy that said my definition of a failed airway is I can't tube once, I now do surgical. Okay, you've got to have a definition. And there's a kind of a definition out there, this failure of 3 attempts by an experienced airway operator or the inability to maintain saturation of greater than 90% through bag valve mask. That is an accepted definition of a failed airway. So you've then got to take measures after that to see what you're going to do next. Now that we have a definition, we can move forward. Do you have a plan? What are you going to do? Are you going to put a pillow in if it's not a trauma? Are you going to change your blades? Are you going to run around the room and scream? What are you going to do? You've got to have a plan. And the best thing is to have pre-thought this plan out now, so you're not trying to think of a plan right then. So the first thing I'm going to do is this, the second thing I'm going to do is this, the third thing I'm going to do is this, because this is what works for me. This is what I've done at the workshop and I found it works. This is what I've done in my practice over years and I found it works. Have a plan that you stick to, okay? Are you going to stick rigidly to every plan? No, you're going to change it a little bit. But the same approach, the same equipment, you're going to use over and over again, and that's basic equipment. Now, you've got to have your own plan, all right? Now this is kind of a, we don't want to go through this, but this is what a normal kind of failed intubation protocol looks like. You know, you have a go, you have another go, put a pillow in, change a blade, get another operator, get a low carb cappuccino set up, do see if there's somebody else around that can help you. Can you ventilate and oxygenate? We'll let them wake up. Right, you know, or if you can't, what are we going to do now? You jump up and down. You might do a surgical airway. Get me a cannula. Do we have three-way taps in this department anymore? I don't know. What are we going to do? Okay, that's what usually happens. And if you look at the anaesthetic protocols, everybody gets woken up. It always goes down to the, oh well, we can't do it. Let's just wake them up. Do it again later. It's not an option for us. This is my plan. It won't necessarily suit you. But this is a plan that I use. If I can't tube, I'll have another crack at it. Okay? If I can't tube again, I will use a bougie immediately, because then I'm about to go into a failed airway protocol, remember? Failed airway definition. I then say, is there somebody here that's more experienced than me? This is not about pride, this is about getting the tube in. Say, is there somebody here better than me? If they tube, fine. If they can't tube and it falls back into your hands again, I use an intubating laryngeal mask, an ILMA. Okay, I use one of these. Most EDs have these, right? If for some reason they don't, I just skip to the next bit of what I do. When I tube, I do everything in order to make that tube work the first time. I don't just go, you know, give me a tube, I've got my laryngoscope and off we go. I do everything to make it work. I position the patient appropriately. I'll put an introducer in. Every tube I put an introducer in. I shape it myself because I know this is the shape that always works for me. 40 degrees, 35 to 40 degree angle always works for me. And it may always work for you too. Something to think about. And I like this angle because I tend to see this angle a lot. And I'll see it a lot. Must be a good angle, okay? So I will do everything that I don't have to get past this stage. But I'll try it twice like this. If I can't get it in, I will go to this. The chances of me missing a tube with one of these is almost zero. If I put it in the right way. Bent bit goes in. I've often seen people trying to intubate with this end. Okay, you're going to miss it. And I'll demonstrate these to you when we do it. If that all fails, I will try an intubating laryngeal mask. Okay. If they don't have one where I'm at, I will valve mask the patient with cricoid and have a little think and say, is there something else that I can do before I ask for the scalpel? So, intubating laryngeal mask. Let's just quickly look at that. Who here has used one? Yeah, okay. So you take all the air out of it, you try and flatten it out, okay, as much as you can. And then you put some lubricant on the back. Not on the front, because if it hits the vocal cords, they go into laryngospasm. So put it onto the back, and once we put it on once in here, you don't need to put it on again. Then you just pop it in. Notice the finesse with which that's done. Just ram it straight in. And you hold it in. Now, you can bag through that, and that's like a laryngeal mask. And I'll show you a laryngeal mask today. But unless you put a tube in, you haven't secured the airway. So now we have to feed a tube through that and make sure the tube is secure. The decision to do the surgical airway is the difficult part, not doing it. Doing it, 3-second procedure. You'll all do it multiple number of times. Surface anatomy.
So the sternal notch is where we begin, and we feel upwards in a cephalad direction until we hit the first transverse notch. And in this patient, it is right there. If we feel above it, we feel a small divot or give way, which is approximately there, and this is the cricothyroid membrane. This is where we would be aiming with our needle. could you please swallow for us? As we can see, the laryngeal prominence, or what we would call the Adam's apple, moves every time the patient swallows. Can you swallow again? That's fine. Now, as we feel the anatomy in the midline, we can feel the laryngeal prominence, and right below it, this is the cricoid ring just below. Thyroid cartilage, laryngeal prominence, cricoid ring, cricothyroid membrane in the middle. It's fairly simple in the male.
Almost
Fairly
obvious.
simple.
You can see it in him,
In
he's
the male.
thin. But the rest of it is all by feel, okay? Females start low. The first bump is going to be your cricoid ring, then a divot. In a male, start at the top. The first thing is your Adam's apple or your thyroid prominence. Go down, the first divot's going to be your cricothyroid membrane. Really easy when you do the anatomy like that and you approach it and you've had a little bit of a think about it. Needle cricothyrotomy. Needle cricothyrotomy is used for 12 years old, actually varies in the literature. Anything from 10 to 14 is what they say, but usually about 12 is about right. You don't do a full cut, as we said, in the younger age group for a number of reasons. One is it's not big enough for us to fit a tube through. Two, it's friable, hasn't developed enough yet. So when we stick a needle in, you'll stick a 14 gauge in, straight in, and what you'll end up doing is, and you can try this today, we've got a 14 gauge here, and you'll put it in on the end of a syringe, and you might fill the syringe with a bit of normal saline. And so as you're putting it in, you pull back, okay, and I'll show you that in a minute, I'll show you the procedure in a second. But you'll get the bubbles. Once it's in, you then use jet insufflation, and you'll see jet insufflation done now. The important thing about jet insufflation is knowing how much to put in. If the patient's less than 15 years of age, you go, remember you got the little grades on your oxygen, you know, little 1, 2, 3, 4, 5, up to 15 litres. For every year, you go up 1. After 15, just ram it straight up to the top. And I'll show you what's important about this. Needle cricothyrotomy. So I always put in a bit of normal saline in a syringe and attach it in. And you go in at about a 30, 40 degree, 45 degree angle. So you've got to find the anatomy first. And the important thing with any of these surgical airways, whether it's needle or full surgical, is you've then got to hold the anatomy down, okay? You've got to hold it down so it doesn't move. So, I'm sorry, my hand's in the way, I'm holding the anatomy, but you'll see the bubbles coming up in a second as I'm in. There you go. I'm in the airway. And then you feed the hub down. And you pull the needle bit out and get rid of the cannula part, and you now have the hub. Now I'll take my finger away in a second, but the most important thing you can do is never let that go, because you will lose it, okay? You see, I'm overprotective of it even on a mannequin, all right? Never let it go. Then you've got to try and ventilate through that. One way to do it is to get a 3mm syringe, take the plunger out of the 3mm syringe and just attach that bit into it. Then take the top of a 7mm tube, endotracheal tube, straight in, and you can then attach a bag valve mask directly to this and bag. How easy is this to bag? Really difficult. The resistance is massive. This is great for less than a 5-year-old. You can bag quite easily, because remember, that's all they need. But any older than that, you can't do it. So a better way to do this, if you were going to go down this road, I've let it go, is to use jet insufflation. What I do is I just take the oxygen off the end of a bag. I'm kind of very simple. Use things I have. You know, this is the MacGyver of emergency medicine approach. And I use a 3-way tap. I just stick it onto one side of a 3-way tap. I put it straight in, having used my Swiss Army pocket knife to make the incision, of course. Straight in, and then, and this is the key, you've now got you've got an open port in there. So 1 second on, 4 seconds off. So 1 second so the oxygen goes through, 4 seconds off so that they can expire through there. You've got to let the air out. So 1, 2, 3, 4. 1, 2, 3, 4. That gives you enough. How much time does that buy you?
45 minutes.
Okay, I was hoping somebody would say that. That's what the literature says. What is the reality when you've got your bicycle clips on, you've pooped in your shorts, we should cut that bit out, and then you're working in the ED? 15 minutes maximum, 10, 15 minutes. You really, really are going to be pushed any more than that. You can't, these are all the other kits. I have to show you these as part of any emergency syllabus, airway syllabus. This is the Malka kit. And a lot of people might have this in their difficult intubation. But if you've never used one before and you're using it for the first time, man, you're going to come up with some issues. So you've seen it once in a workshop, or you've done it once or twice in a tutorial at your hospital, and then you never see it again. And these are the bits in it. They got a bit of a cannula, which you're going to use like a normal 14 gauge cannula. You've got the syringe, you've got a wire there that you're going to have to use, and you've got this little contraption which is a 3mm internal diameter cric and an introducer, etc. The problem with this thing is, though, it is not cuffed. You need a cuff in the trachea to protect your airway. Remember that? You can't put this in. You can, but it's no better than, as far as I'm concerned, than a laryngeal mask. You're not protecting your airway at all. The beauty is there are some out now that are cuffed. So once you put the cannula in with this, you're supposed to feed the wire in and then take the cannula out, and then over the wire you're supposed to feed this little divot here. So whack it straight in. It's got an introducer in there. You put it in, then you pull the introducer out and you stick the thing in. But again, not cuffed. Doesn't have a cuff on the end of it, so it's not a protected airway. And then you tie it all up and you stick it in. It's really easy to bag through it. 3.5mm internal diameter, really easy. But it does not protect the airway. So if they regurgitate, very easy for that vomitus to go straight down your trachea. So useless to know how to use this, because it doesn't protect your airway as far as I'm concerned. But it's part of any normal airway kind of protocol stuff you need to learn. So that's great. You've seen it now, okay? Now let me show you how you put it in. So you've done this, you've whacked that in, we've been through this stage. Okay, you've got it in, you never let that go. Now you put your wire in. So this is a Seldinger technique. Anything where you feed a wire into something is a Seldinger technique. And then you pull the cannula over it. You've got your wire still sitting in there. And then there's your two bits. You've got your introducer, which is the grey-ended bit. You feed that through. Now remember, no cuff on this. But you whack it in. Fantastic. And then this is the most difficult bit, threading it over that. So I've got my trifocals on. I've got everything while I'm doing that. And then I'm in. Now most cases, you can't feed it through the skin, so you're going to have to put a little cut in the skin. Okay, so your little scalpel that comes with it, do not cut the wire. I repeat, do not cut the wire. Or it's an episode of ER or something that you're in. Okay, do not cut the wire. Then feed the thing, push it straight in, pull the wire out, pull the introducer out, bang. But patient vomits, goes into the lungs. Well done. Okay. If you want to do it and this is the trachea, pig's trachea, we're doing exactly the same thing on a pig's trachea. Little cut in there. You've gone through, easy to feed, lovely. If you've got a cuffed one of these and this is what you like doing as part of your difficult airway protocol, that's fine. My approach to this is universal precautions, as I'm telling you. Make sure you slop a bit of betadine on if you need to, if you're doing the full surgical airway. Now, all you need is a couple of bits of equipment. Okay, a bit of gauze, because they will bleed. There's a couple of vessels that pass right through the cricothyroid membrane. You're going to cut those vessels and they will bleed. And anything you've got, a set of mosquitoes, a set of suture forceps, whatever you've got at your disposal, because when you make the cut, you're going to put those in. And the technique I show on this one, I'm going to show you a slightly different technique today, which is an even better one than this. If you fail to plan, you plan to fail, little thing I say. So you need to have a plan. By the end of the day, I want you to tell me your plan, and I will individually ask you, what will you do? Have a think, have a think. Special cases, let's go through some special cases. Raised intracranial pressure. We used to give them lignocaine. It doesn't do diddly, all right? Succinylcholine may increase intracranial pressure. I don't defasciculate anybody. I give them thiopentone, it decreases it, it balances it all up. It's very momentary, it's done. Rapid sequence intubation is the best way for us to maintain control of intracranial pressure. We want to avoid PEEP. If we give PEEP in a person with a head injury, we might be increasing intracranial pressure, and we aim for a normal PaCO2. We used to hyperventilate these patients because what we used to think was we used to decrease venous congestion. There's no evidence for that, and all the studies have shown there's no evidence. Airways disease. This is what we spoke of when we said that post-intubation care was more important than intubation. So intubation is the easiest part for these patients. The problem with it is they hyperventilate, they auto-PEEP, they cause barotrauma. So you want to go for a low tidal volume in these guys and permissive hypercapnia. So you go, instead of 10 milligrams per kilogram, you go for 5 or 6 or 7. You want to have an inspiratory to expiratory ratio that's quite long. So inspiratory 1, expiratory 4, 5, 6. Every now and then you might want to disconnect them and get the air out of their lungs, okay? This is what's most important in asthma. I will guarantee you, if you give them Sux and Thia, you'll tube them, you'll get it in, there'll be no issues. This is the thing you have to manage, not the tube. The tube is like any other, okay? Acute pulmonary edema, they come in often. These guys crash and burn very quickly because they're volume depleted. And so we used to do these sitting up intubation awake tube pretty much in the old days. It's better to get it under control, get them tubed, and have something ready to give them a little bit of support if you need to, but that's all. So what you might do is they can't lie flat. Remember, these guys they're tiring now, they're agitated, but they can't lie flat. So we might give them something, knock them out whilst they're sitting up, bang down, tube, okay? So they don't fight you. Give them the largest tube you possibly can with these guys because you want to minimise the resistance to ventilation. You want to get it in. How does, and PEEP, yeah? You want to give them some pressure. Obese patients, I had a guy that was 220 kilos. The thing about the obese patient is they've got a lot of tissue, okay? This is the problem. They've got tissue everywhere. And when you try and get a laryngoscope in, when you're trying to tube them, you might get the tube in. When your chest is out here, you can't actually get the handle in order to get any purchase. And so you can sometimes use a short-handled laryngoscope if you've got one in your department. Most departments won't have. The best thing you can do by far is set up a stepwise approach of blankets. You want to step them up because what happens is if you set a step up and you sit them up, what ends up happening is they do this, so their chest and arms and shoulders fall away and their throat comes up. Positioning in these patients is probably the most important thing that you can do. Non-intubation, non-invasive ventilation. Really quickly, this is everywhere now. You need to know BiPAP, CPAP. You can avoid intubating quite a number of occasions if you know how to do this. It is good in APO. Yes, yes. Is it good? Who thinks it's good in acute exacerbations of COAD? Raise your hands. Yes, yes is the answer. Everybody's hand goes up. Okay. What about chronic COAD? Not proven. Doesn't make any difference in chronic. So in acute asthma, you might even use it. In acute COAD. In chronic, no use. In APO, good. Okay? So if somebody comes in acute exacerbation of COAD, you give them a bit of CPAP, you can give them a bit of BiPAP if you want it, but CPAP will probably work quite well. There's a certain group of patients that do better. Your patient needs to be awake, right? So they can tolerate it. They need to be able to tolerate it, the patient has to work with the machine. Okay? They have to work with the machine and allow a breath in. What are the usual settings on BiPAP?
5 and 10.
5 and 10, 11 and 6. You know, give them about a 5 gradient difference between the two. So you want to have some positive pressure when they're not breathing in, so you keep all the alveoli open. Yeah? There's a certain group, the ones that have got a better blood gas, they're not that acidotic, that supposedly do better, but that's probably because they're slightly less sicker. So the kind of, you know, if your patient's well, they're going to do well, okay? You want to trial this first, but be prepared to go to a tube if your patient's tiring too quickly.